Good evening, ladies and gentlemen, to this late evening session. I'm sure we are all a little bit tired after this very long London Valves Day, but I can assure you this session will be hot. It's interesting. We picked up some very challenging cases to present, so it's worth it, and I'm sure that we will have a lovely discussion, interaction with you guys. So it's a TAVI case in point session sponsored by Medtronic, and the theme of the session is technical challenges and optimal device choice for complex TAVI procedures. My name is Mohammed Abdul Wahab from Germany. I'm joined here by the moderator Mati Adam, also from Germany, and we have a very lovely panel. Sonia Petronia from Italy, you all know her, Gay Atizani from the United States, and Chris Malkin from the UK. And the objectives of the session, as you can see on this slide, would be to learn how to anticipate risks of specific valve and valve procedures, particularly in small surgical valves. We'll support this by a very interesting case. To understand valve choice and implantation technique in patients with complex native aortic valve disease, also a very interesting and challenging case you'll see. And then to discern the latest technological evolutions for treating complex anatomies, a little bit looking into the future, what we expect from future device iterations. Mati?
Thank you, Mohammed. Really great introduction, and I can only underline what Mohammed just said. I mean, there is 3 great cases coming for you, and I think it would really make it even more worthwhile if we're really trying to engage in a discussion. Guys, use the app. There's going to be votes. Let's have your opinion here. Press the interaction button and then go to room 2. And vote with us. Also stand up, use the microphones. Really, let's make this interactive. I think this is something that at this time of the day is probably going to have the most impact on all of us.
Yes, and I can assure you the cases that are going to be presented are really very
outstanding.
Yes.
Absolutely.
Okay, so let's move to the first case. Sonia?
Okay, here we are. These are my conflicts. So, I will present to you a case of a female of 77 years old with the previous surgical operation with a Freedom Solo 19 in 2014. And of course, she was scheduled for TAVI due for a prosthesis failure. And the AERO score was 80.8 and the STS was 4.2. So, of course, you imagine that the valve we're going to put was a small valve because the main diameter was under 19. But we can observe here that the VTC for the left coronary artery is less than 4, so with a high risk of occlusion. And the VTA was 2 millimeters. You can see that the STG is not only calcified, but you can focus that you can see the leaflet of the valve that are higher than the plane of the STG. While the VTG of the right coronary artery was small, but the right coronary artery, fortunately, was hypoplasic. So if we want to classify what was this case, we could actually position it in the type 3B because the leaflet of the valve were higher than the SVG and the sinus of Valsalva were really very small. So assessing the risk of the coronary obstruction, of course, we needed to do something because the occlusion of the coronary artery was very high. So, what would you do in treating, what option would you perform in your center if you had a case like that? A simple valve-in-valve. A valve-in-valve with a chimney technique. A valve-in-valve with a preventive leaflet laceration, or send it to the surgeon.
Sonja, thank you. I mean, great questions and also a great case that you brought. I mean, this is really a nightmare case, kind of like we were talking just before the session. I imagine an Italian small lady, right, with like super narrow ascending aorta, sinuses, and an annulus very small after surgery with a stentless valve. I mean, this is really 3B anatomy. I mean, this is really a challenging case. So I'm really looking forward to what we're going to have as an answer on our poll. Also, I will introduce Susanne Katz, who's our chat master for today. And if you are remotely looking the session or watching the session, please enjoy chatting with her. And then we'll pick up your questions here.
Yeah, so
we have already the
participants are already answering the question. So let's see, this is a live poll. Interesting to see that
it moves.
Yeah, still
new
moving.
participants would use a valve-in-valve without any protection. Valve-in-valve with chimney, 26%. Valve-in-valve with leaflet laceration, 43%. Probably these are those guys who attended the morning session. And surgical AVR still in 17%. So maybe let's see if someone would like to comment on the fact that a valve-in-valve with any prevention would be feasible. Nobody is outing himself or herself.
Well, valve-in-valve with 10%, it's high.
Yeah, it's high. Gay, what do you think?
Yeah. No, I think to consider what type of treatment in this case, obviously the surgical risk is important, but also anytime you consider doing anything additional other than an actual valve-in-valve procedure, you have to understand not only the risk of the patient, whether or not there is patient prosthesis mismatch embedded in this specific patient. It's not only about considering the risk, but also the level of activity of the patient and how much of real risk of whether or not there is frailty embedded. So it's a very comprehensive consideration to decide, because as you well pointed out, right, it is a small valve to start with, and even if you get away, you can treat the patient, you're going to end up with a potential chimney stent, or you're going to add risk to the procedure overall. So that needs to be taken into account when deciding, because this is not going to be probably like a walk in the park type of valve-in-valve case, and a surgical redo. I think I would definitely consider a surgical redo in this case. I think it's something to take into account for sure.
Yes, I would say that if you compare the simple valve-in-valve or surgery, probably surgery would be better.
Yeah, I mean, looking at the
if you didn't have any opportunity.
Yeah, looking at the measurement you have shown, I think it's a clear case of a high risk of coronary obstruction.
Yes.
So let's agree that doing a valve-in-valve without any sort of protection here could be extremely dangerous, and we know this from the measurements we have. So you either think about surgery, which is an option, of course, if the patient's operable, or you think about some sort of protection. I mean, this is an Italian valve, the Freedom Solo.
Yes.
Yeah. You see this often in Italy. It's a very nasty valve.
It is a nasty valve because it's supraannular sewed, and the coronary artery get really very at a low height from the annulus, the new annulus, and in some way the sinus of Valsalva, it's changed. So even if you look for surgery, redo surgery, it could be a problem for the surgeon too.
Yeah, I mean, it's a stentless valve, which makes it difficult a little bit to treat from an interventional perspective. Probably, I'm not a surgeon, but I think surgeons implant it in a supraannular manner.
Yes.
I think,
exactly.
And it has huge leaflets. The leaflets are extremely long. So the moment, maybe this is an important message to take as well, the moment you see a Freedom Solo,
you run away.
Or at least you pause and think. Yeah. Chris, do you see this valve often in your practice in the UK?
No, fortunately not. We have a lot of mitral flow in my part of the world, which presents much of the same challenges. This looks like a case where it's a guaranteed coronary obstruction to me, and I think the strategy kind of depends on where you are in the world, what your skill set is and what your support is. I don't think TAVI with a chimney is a good option if surgery is any potential solution.
Yeah, I mean,
there is a characteristic of this patient. If you saw the CT, there was a big calcification and the VTA was very small, was 2 millimeters, and there was this bunk of calcium. So and only a chimney would probably not able to expand the stand completely.
Yeah.
So we were frightened of that situation.
So you really need to look at every detail of the anatomy in such a case before deciding on the best or ideal way to prevent coronary obstruction in such a case. I mean, I know chimney is the way the interventionalist probably knows how to deal with the coronaries, but in this particular anatomy with this very small STJ, you probably end up with a crushed stent.
Yeah.
And is to say that it happened to us, to you, to have to re-engage coronary artery after a while in a chimney, and it's a nightmare.
Yeah, this is probably not
easy.
Not something you want on your night shift, right?
Absolutely.
Yeah.
Okay, so let's see, Sonia, how you treated this challenging case.
So first of all, we shouted help. And these are the imaging of the laceration of the left cusp. You can see here there is the wire that gets down and the lasso, and in the right part you can see the cut of the leaflet. Then, after that, we engaged the left coronary artery as to perform a chimney, to protect the coronary artery with a stent, with the technique of a small catheter inside the guiding catheter. And then we positioned the valve, which was a supraannular self-expanding valve, and we performed a post-dilatation with a protection. After that, we wanted to see if we were safe or not. The patient was stable, but it was difficult to say because we didn't have space in the sinus of Valsalva. So we did like a ping pong technique, and we engaged the coronary artery from the inside of the valve. You can see here the wire getting close to the other wire. Then we performed an IVUS, and I hope it moves in some way, because it should move. But you will see in the few images of the IVUS that you could see a little bit of the piece of the leaflet of the Freedom Solo that was very close to the ostium. I don't know why it doesn't move.
Can you try and move the video?
Move the video of the
upper
IVUS,
left
please.
panel with the technical team.
Okay, that's lovely.
thank you.
So you will see, yes, see here, there's a bit of thick, let's go again. You can see first the coronary artery, and then between, let's say, 10 o'clock and 6 o'clock, there is a thick fibrotic tissue that probably was the leaflet. So we decided to position a stent, but this time not a chimney technique, but the stent from the inside of the evolute. You can see here the position, and we calculated a couple of millimeters inside the evolute, not more. And you can see that the stent protrudes in the valve. Then we observed, IVUS again, what we have. Can you play it, please? And you can see here that there is a good expansion because we didn't have the calcium close to us. And you can see that it's expanded and it goes until the inside of the TAVI valve. Stop. Okay, see if it works. Okay, and this, it's the final result. You can see it's both coronary arteries and the position of the valves. It's nice. The patient kept stable, and went home in 48 hours. So what I can conclude now that valve-in-valve is not always a straightforward procedure, as we were saying before, that sometimes you need not only one technique to perform. And the important learning that we have is that to do laceration, but not only that, other techniques, you need to have a learning curve. You don't have to sort of investigate and try it. And it's very necessary to plan the procedure from the beginning, knowing exactly step to step what you think you should do. Thank you.
Yeah, thanks. Great case.
So just a comment. I think it was very elegant, very important. I couldn't not stress more what you just said, that planning is key, right? Just a quick comment in terms of the stent, right? After you did your IVUS, you didn't protrude your stent as much. You didn't do like a classical Chamonix, because normally when we do a classical Chamonix, we protrude much more to the aorta, right? Could you just elaborate a little bit on that? Because I was observing, it was perfect, excellent result. Congratulations. But
well, in some way, we copied what surgeons do when they do a Bental. They re-engage the coronary ostia. So we thought that putting a stent like as a bridge from the new TAVI to the coronary ostia would allow us to engage the coronary arteries again, and you could do anything after that without having problems of the stent struts or
and this is
crushing
actually the advantage of lacerating the leaflet beforehand. So you're not doing a chimney, but you're doing orthotopic stenting. So you're stenting through the slit that you performed with leaflet laceration. Because, I mean, with this very, very small sinus, probably pushing up the leaflet will not be completely enough to secure a completely free ostium. So you move the leaflets apart, you keep flow, but still you have some leaflet tissue in the vicinity of the coronary ostium, and you just use the stent to make sure that you have a clear pathway.
And another thing is that we did the laceration, and we were able to do all of this in a stable situation. The patient was fine. The leaflet were a little bit apart because they were not in front of it, so we didn't have to rush. We had an angio, we had an IVUS, we were discussing, and it was probably not one of the two options would have completed all the problems.
I absolutely agree. Sorry, Mohammed.
Yeah, but let me ask you, Sonia, about the implantation depth of this valve. So a lot of the audience would think, oh, why did Sonia implant the valve that deep? Could you comment on that?
Yeah, Wes, it is not only this case, but we've been discussing that we didn't want to implant the valve very high. And I think that this is going to be something that we will reconsider in some way, because having to engage the coronary ostia sometimes and having the valve too high, it's one problem more than usual. You have to do what is a medium height, and this was around 5 millimeters, I think.
Yeah. I mean, this actually was picked up in the chat also, Sonia. So people were asking, did you deliberately put the valve on, in that position with that height? And I think, as you just pointed out, it's really important to think about where you put your valve, and high is not always the best, right? So before we move on, Mohammed, I just want to try to interact with the audience one more time. I mean, clearly, something like a basilica procedure is something that's off-label use and stuff, and it's probably only available in experienced centers. So I just wanted to ask if how much of you guys have done a basilica and have access to us, or would actually know whom to ask, or is this something that's super not connected to you? Do you think that it's never going to happen that you have a case like Sonia because it's only in small Italian ladies and never happened again? Or is this something that you would think is important and we need to talk more about? So who has done a basilica procedure here?
1, 2, 3, 4.
4. And who thinks he would love to do one but just doesn't know who to ask? All right, so there are a couple
Also
of
a
more
small
guys.
number, right?
Yeah, but still a small number.
And who
right?
thinks that we don't need basilica? We do chimney all the time? Nobody. And the rest is neutral or passive or? Okay.
Right.
So I think we had a session this morning actually focusing on acute coronary obstruction. It was fully packed, and we understood that the majority actually of people, they do believe that we need some sort of training to understand how to do it. It is complex because we're using off-label material, but it may become easier in the future if we get like some dedicated device. So by that, let's wrap up the first case. So to sum up, a case with a challenging, small, failed surgical valve, a very special valve. We understood Freedom Solo is a valve where we need to pose, need some considerations regarding the risk of coronary obstruction. There are many methods to prevent. Sometimes you need these methods in combination. It's very useful to have a device with supraannular function because we achieve good hemodynamics in these small surgical valves, but then you should pay attention to how to implant the device in order to get the benefit, the hemodynamic benefit, but also get out of the procedure without coronary obstruction. Chris, the second case is not less challenging.
Thank you. Oh, thank you very much for inviting me to contribute to this session. I'd like to present a relatively young woman who was treated in my institution this year, presented with heart failure, very unwell, with critical valve disease. She was worked up in standard fashion. Importantly, she had an abnormal right heart, chronic pleural and pericardial effusions, and she'd had a stroke for which she had some permanent disability. She was felt to be frail, had some lung disease, and was overweight. We did a CT, which you can see here. There's a few things that are pertinent. Firstly, this is a type 0 bicuspid, which is heavily calcified. And there is quite a discrepancy between the measurements in the annular complex. The LVOT is fairly small, 23. The true annulus is larger, 26. And the supraannular measurements here, I've used a sort of floating ellipse measurement, is smaller. Also, as you can see in this moving diagram of the aorta, there is very abnormal shape to the aorta. There is a kink in the thoracic aorta and marked unfolding. As we come to PA, you can see that the ascending aorta is kind of on the other side of the body. So there's a few challenges here that present with this patient. So it's a very simple question, which will go to a poll. What would be your treatment option in your centre? Should it be surgery, or should surgery be reconsidered if TAVI was initially felt to be the best option? If not surgery, would you do TAVI with a balloon or a self-expanding valve?
Great. So again, use your app and give us your opinion.
I mean, again, this is a great case where all of these options could apply to people, right? I mean, so for me, I mean, if you just look at the facts, I would think about surgery, but like you think RV impairment, so that's something that, you know, you don't want to go through surgery. So it really is something that you might want to decide in a team, surgeon, cardiologist together, have a look at the patient, decide how fit is actually, you know, the day-to-day activities that this patient can undergo, and it's a very challenging case. Do you think that, you know, when people are answering this poll, it would affect type 0, type 1 bicuspid valve? Is there an implication to this? Maybe that would change people's mindset about answering this question, or?
Well, type 0 is the least common that we treat, I guess, apart from type 2, which is extremely rare. The sizing algorithms that we think we can use for bicuspids are not necessarily reproducible for the type 0. I mean, in this case, we did reconsider surgery, and the patient did not pass the sort of end of the bed test. And I guess your decision process is based on how confidently do you think you can get a good result with TAVI. There were some ongoing concerns going into the procedure, namely the sizing, which we've talked, and the aortopathy or aortic shape. But I think a type 0, it's different. We treat it much less frequently, and the unfamiliar is potentially more hazardous.
I think for me, more than whether it's a type 1 or type 0, is the phenotype of the bicuspid valve. The distribution of, sometimes you have those very heavily calcified valves with very bulky calcium. Those valves are not the ideal ones for you to treat percutaneous. Obviously, you're going to do it if the patient is not a surgical candidate, right? But every time I consider treating a bicuspid valve, I always pay attention to the phenotype, the distribution of calcium, not as much whether it's a type 1 or type 0, but rather this whether or not there are chunks of calcium distribution, sometimes returning to the LVOT. I think these have to be taken into account when you're going to decide which valve and what to do.
But I mean, we're asking now, I mean, only 10% voted for surgery, and it appears the patient, despite being young, she's really a high risk for surgery. So it comes now to the choice of device. I mean, forget that we are in a Medtronic session. 34% said a balloon expandable and 56% said a self-expanding. From your point of view, what would be the pros and cons of each device type in this setting?
Yeah, there's
this particular patient.
Right. As we know, there's no like direct comparison between these two in this scenario, obviously. But I would feel personally more comfortable using a self-expandable valve in this case. Number one, because of the hemodynamics, right? And that there's a very huge. I couldn't see like the whole district. I would like to see the CT in its entirety, but you can see that there's a big chunk of calcium there, and that to me, I think would increase the likelihood of having complications with the balloon expandable valve. So I would pick a self-expandable valve.
Yeah, fear of anal rupture.
Mohammed, what would you do?
Good question. Yeah. I mean, both are challenging. I probably would talk to my surgeon again.
Yeah. When I saw the first slide coming up, I was like, oh, this is going to go to surgery. But then the RV impairment and the stroke came up. And so I'm pretty sure it's not a good surgical candidate. I think I would go for a self-expanding valve as well, just, to feel safer, have more time, let the valve adapt to the natural annulus.
But if you're going to tackle, and I think this is why we're discussing this, if you're going to tackle such an anatomy, you need to be aware of the challenges that you might expect along the way. Yeah. So it's not a straightforward procedure. The aorta is extremely tortuous, and the valvular anatomy is not very inviting. So you need to be aware that you may run into trouble.
But you can even, with a self-expandable, you can even sort of reposition and change the position, which in this case can be crucial if you want to have a good expansion.
Yeah, these are the two advantages of a self-expanding platform. The setting, you can adapt. It's not an all or none implantation. And probably you are a little bit more friendly to the anatomy.
Yeah, but you made a good point. You have to take into account that tortuosity in the aorta, because that's gonna, start some tension in the system and makes the deployment harder. And that's we're gonna talk about the evolute FX in the end of the session, but that's a situation that I think the FX has an advantage, because the navigation of the device happens in a much smoother way.
With the current system we have in Europe, we still have less flexibility. Questions from the...
Yeah, we have a question which is actually combining the first and the second case. So Henrik Nissen is asking us if we could consider basilica before TAVI in this case to make it a tricuspid valve, which is actually quite an interesting concept, I think. I've personally never done it, to be entirely honest, and so I have absolutely no experience with it. But the concept is intriguing, right? Has any of you guys ever thought about something, done something like that?
Yeah, thought about it, but never did it. There are a few case reports, I think, published, the bisilica procedure from bicuspid.
Perhaps it's the chunk of calcium. It could play, further difficulties in
the idea is probably to cut alongside the calcium, so not cut the calcium, but alongside the RAFI. And maybe this could help you getting more expansion, but definitely something that is also off-label, and we have very limited experience with that. So Chris, you want to move?
Chris, before you move on, one question maybe from my side. Or who would pre-dill aggressively or not so aggressively? Who would not pre-dill? Is pre-dill something in bicuspid valves that's set for you? You're always going to do it, or I mean, we're going to see what you will do, but what do you think about?
So I mean, I always pre-dill with bicuspid really, unless the patient is in extremis and pacing is hazardous. It also just helps me understand what's going to happen. Where do the leaflets go? Where does it indent on the balloon? The size of the balloon helps me confirm my original decisions. There's lots of little bits of data that help me, and I do believe you get better expansion. So almost always yes.
Yes, for sure, predilation in this case. One thing you have to be aware of this is this patient has severe RV dysfunction, right? You have to be careful. I prefer to use a true dilatation balloon because it rarely watermelon seeds. It's one rapid pacing, very quick and done. Sometimes if you use a semi-compliant balloon, it moves 1, 2, 3 times. You have to keep rapid pacing the patient. These patients with RV dysfunction, they just don't tolerate that very well. So just be mindful of that.
I always predilate. I would not be aggressive. This is something I would not do.
And then adapt to the floating ellipse maybe more, or, you know, there's going to be, I mean, we could talk about pre-dilatation, I think, quite a long time, but we'll let Chris get to it, I guess.
Well, there's another poll actually. Yeah, so we're getting down to the kind of decision-making process. So this applies whether you chose a balloon or a self-expanding valve. Are you going to size to the annulus, which is 25.2, or will you downsize to the LVOT or to the supraannular measurement, which is the floating ellipse, which I've quoted there? That's interesting.
Where do you measure your floating ellipse? You always do it 4 millimeters, no questions asked, or are you in the CT like scrolling up and down, looking where you think it's actual, like oval, and then you're measuring there? Because I start at 4, and then I honestly look for what suits me the best, where I think it's actually oval and where we actually.
I mean, that's a great question. I mean, when I do a report, I quote at 4 and 8. But when I'm about to do the procedure, I do exactly what you say. I scroll through it and get a feel for the ICD and the floating ellipse at every single level. And I mentally take that into the room and say to myself, if I leave the valve at 0 or +2, what is the measurement there?
Yeah.
It's a dynamic sliding scale, I think.
Yeah.
Okay, so the majority would size to the annulus. Tell us what you did, and fasten your seatbelts.
For sure.
Okay, so we are going with an undersized self-expanding valve. This is a 26 Pro Plus. There's a pre-dilatation with an aortogram on the left, and I like to do that because I like to see what happens to the balloon, where the indent on the balloon. If you could just play the first video again. And I work very hard to not allow the balloon to melon seed, so I do get a feel for the anatomy. We did not go into this case without some anxieties. There was real difficulty in tracking the evolute capsule over the aorta, and actually you would normally go to LAO to do this, but because this lady's aorta was completely displaced on the other side, actually we're going almost RAO there and torquing the catheter completely the other direction. So the flush port, not at 3 o'clock, ended up at 9 o'clock. So really thinking on our feet, adapting to the anatomy and working with the patient's anatomy rather than against it. But eventually, with some coordination with countertraction, we're able to get the valve to the annulus.
Chris, can I ask a question? So I see you put a pigtail through the radial there.
Yeah.
Wouldn't you consider doing like a contralateral femoral? Because that tortuosis in the descending aorta, using like a buddy wire and a stiff wire would help you probably go up. Did you think of that, or?
We talked about that up front. We would have gone to that at a very low threshold, but I felt we were making progress. I mean, there is some morbidity in puncturing the left leg. There's always a price to pay, but we would have a low threshold for putting a small sheath in and taking a stiff wire in the marker pigtail, or even crossing the annulus with a buddy pigtail in the LV to help it make that final transition.
And so because it comes up in the chat, what's your go-to guide wire in a case like this?
There's a Safari small.
Would you think about, increasing stiffness with the Lundequist, or for example?
Occasionally, but I would always try with a Safari first. The advantage of a self expanding is you can take it out and start over. So there's just a degree of safety with the Safari. I think that there's a price to pay with the very stiff wires, I think.
Yeah. Thank you.
So here is the implant. We've deliberately downsized, so we are starting high and keeping high. And there's a period of rapid pacing to go to sort of 70-80%, which you see on the right. And the valve is making a slightly odd shape, as you can see. And if I go to the next slide, what we get here is a perfectly stable patient. With the valve at the desired position, it's very constrained in one dimension. It's not constrained in another dimension. It is completely competent and is working. But now it really is decision time. So it's time for the final kind of poll. So what would you do now? Would you recapture this valve and move it somewhere else, higher, lower? Would you take this valve out and start over again with a completely different strategy? Or would you deploy the valve in the position that it is now?
Well, it's a really great angio. I mean, were there emotions in the room when you shot this angiogram? I mean, this is like really, something to look at. Right?
Yeah, so I will confess, I lost the room. So I think everyone in the room was genuinely very uncomfortable when I said what I was about to say. Mm-hmm. Yeah, that is true.
Right.
Which is an important feeling because you have an experienced team. They know what you're doing. They know what trouble smells like, and they could see trouble happening here, I think.
Yeah.
Yeah, I mean, it's a good sign. I mean, if the team is laughing at this time point, then the team is not understanding.
Unless they're laughing at you.
It's very distinct this difference, right? While we're waiting for the results of the poll, just one question: what implantation view did you use? It was a bicuspid type 0. I can't remember. Was it left? Like how was it?
The S-curve, it was an very extreme areocaudal, which you couldn't work in. So we went to a near cusp overlap, and eventually we had to modify that still. So we ended up almost PA caudal as it transpired. The main concern here was judging what the valve would do at the next point, I think, and rather than being faithful to the anatomy, it was more important to understand what the evolute valve was doing, I think. So we ended up working in a view where the evolute was in plane rather than being on the S-curve somewhere.
Kind of being old school a little there. Yeah.
Yeah, so interesting, the poll results. So 46%, so less than half of the participants would deploy in this position, and more than half of them would either recapture, deploy lower, or recapture and think of something else. Gay, what would you do?
I would think of the balloon used for pre-dilatation, right? If that's the biggest possible balloon to keep the safety of the procedure, meaning you cannot use a bigger balloon, then probably, so you cannot go with a bigger balloon because you may rupture the annulus. So that's one thing you have to take into account, right? So I think what I would have done in this case, I would probably have recaptured the valve. If that balloon was the biggest one possible, I would have recaptured and then try it again, because that implantation on its own also performs as some sort of a pre-dilatation.
Sort of
and then I would deploy if that was still the case. Whereas if I could do a bigger balloon, I probably would have recaptured and I would have came out. Because again, you can deploy, and I think that the angiogram showing that there's no leak is positive, right? That's a good sign. But obviously, when there is a situation like that, there's always a risk that the valve may pop up, or when you're pulling the nose cone out, that it may grab it. So, I mean, it's as he said. I mean, it's really a situation that it's tense. But I think I would take these factors into account to decide whether or not I was going to deploy it.
Well, if you recapture the valve and redeploy it, it doesn't mean you have to deploy it lower. It just sometimes it's the valve per se. It does like a second valvuloplasty.
Yep.
So it helps you to find the good spot. and it widens a little bit. But I would do the same.
But it's important to stress here that this is not an infolding. So it's an under expansion, but it's not an infolding. Because I think we all agree if it's an infolding, we wouldn't be asking this. We would
yes, of course.
recapture it. Yeah. So it's an under expansion.
Right.
So it's obviously not an infolding. So Chris, what did you do?
Okay. Could you put the slide back up, please? Thanks. Well, I decided to deploy it. I had to persuade my team and my co-operator that this was the right thing to do. We put forward on the catheter, floated the wire and deployed it. And actually the most difficult and dangerous part of the procedure was exactly what you just said, getting the nose cone out. Even though we centralized the wire, it kept catching on the crushed or the unexpanded lower brim of the valve, but eventually we were able to get the nose cone out. And you can see with this rotational angiogram the amazing difference in the expansion in one plane and the under expansion in the other plane. Exactly what we predicted with the floating ellipse that we set up the case with. I did do an aortogram, and because the main reason to do the aortogram was to give me the confidence to post-dilate it, because this is grossly underexpanded. There was a small invasive gradient, but obviously this is a young patient, so this is an unsatisfactory position. So this was a 22 true balloon, so quite an aggressive post-dil. You can see as the balloon goes up, the evolute frame expands and then recoils. So we didn't feel that there was much further expansion possible. And the final result is as you see here. The patient did extremely well. So she started off with an invasive gradient of 100. She went home within 24 hours, so 16 hours after we finished the procedure. Echo 1.9 meters per second, and she's asymptomatic. So it was a fascinating case that kind of crystallizes lots of the problems with bicuspid patients who often have other things that you need to think about. My conclusions, you can do this anatomy. If you plan the procedure carefully, if you're familiar with the device that you're going to use, it's crucial to integrate the CT. Navigating the aorta, we anticipated that it would be different to normal, but we had to kind of think on our feet to do that. And I think downsizing here was actually an important thing to do. Definitely would have been important for a balloon expanding, and I think made the procedure safer with a self-expanding as well.
Yeah, I think congratulations. I mean, it's an amazing case. It highlights again that we have a lot of possibilities with the current technology, but in very experienced hands. So it's definitely a case that needs very, very meticulous planning, attention to small details, a good team that also understands what you're doing, and also the experience and the nerves to be dealing with an anatomy that is as nasty as we've seen. Are there any burning questions from the audience? Or
there are no burning questions from the audience, so I guess in the sake of time, maybe we should move on.
So let's show our final polling question, because I think it's interesting to know your thoughts about the evolution of this technology, of the self-expanding Evolute platform, and what you really think should or could be improved. Can we put out the question, please? The final polling question.
You guys really have to work here for you.
So yes. So what would be the new features you would like to add to the current Evolute platform? And there are 4 things you can choose. You cannot choose all 4 things. So choose the one thing you think is most important. You need a more flexible delivery catheter. You need more predictable deployment. Radio-opaque markers for implantation depth, or radio-opaque markers for commissural alignment. So use the app and give us your thoughts. And maybe we show the, yes, are there? Okay, great.
It's an even split.
I'm looking forward to this poll, right? I mean, many good things on the list.
Was it worth spending all the money on one thing if they vote for the other thing?
Okay. So
Yeah.
it seems the two most important points are a more flexible catheter would be helpful in the case you showed, and markers for commissural alignment. People are like less concerned about implantation depth. They think they do not need a marker for that, and some think that we need more predictable deployment. So very interesting, and I think this sets the stage a little bit to the next presentation, Gay. I mean, you're
Thank you.
from the advanced, from the first world. We are now in the third world in Europe. You're in the first world. You have the new technology. So show us what you guys are using in the United States.
All right, thank you, Mohammed. So I'm going to discuss a little bit about the Evolut FX. We're fortunate enough to be part of the LMR. We've done so far in our center close to 140 cases of Evolut FX. And it's really a great device. So I'm going to discuss with you guys a case that we've done there. Is there all of the above here? There's no all of the above, right, in terms of the option of the poll here? Maybe we're going to show all of the above. So I'm going to present it. This is a very, there's no big highlight of this case. The case is very straightforward. The anatomy, the patient is an 86-year-old patient, moderate to high risk for mortality. And she has semi-frail, but no other normal ejection fraction. EKG, as you can see in front of you there, no significant issues in terms of conduction disturbances. But I like to focus on the case, on the anatomy of the case, basically. So one of the features you can see in this lady, and we actually did this case live in the US for the advanced implanters course, is the fact that this lady has a very tortuous anatomy in her femoral artery, so you can appreciate that on the CT scan. As I mentioned, of course, Sonia and Chris, they showed very nice and complex cases in terms of the anatomy of the valve. This case is very straightforward, a perimeter of 80, a large sinus of Valsalva, as you can see, as well as large STJ. And we decided to do a 29 valve based on these measurements. This is just a regular calculation of the angles for the cusp overlap, as well as the coplanar view. This is our assessment of the coronary takeoff, which also shows very favorable. So the anatomy of this patient is very, very favorable for TAVI overall. So the plan is therefore to go with our jugular pacer. We do all of our cases in local anesthesia. With basically in this case we did, I think, no sedation at all. We do half of our cases without any sedation. And we were going to cross the valve per usual as with the AR catheter. In this case, we decided to go sheetless, as we do in the vast majority of our cases. Some centers, I think, still prefer to use a sheet. We go sheetless. Normally, we used to go with the Evolut Pro and Evolut Pro Plus. With Evolut FX, it makes it even easier to go sheetless, and I'm going to discuss the features of the device that makes it much easier to go and navigate the valve without using a sheet. So it's interesting to pay attention to the fact that with FX, there's no compromise on any of the features of the prior generations of the core valve, right? So the fact that it's self-expandable, recapturable, and supraannular that started back with Evolut R, then with Evolut Pro with the ceiling skirt, and Evolut Pro Plus with the smaller sheet size and the lower delivery profile, these features are all kept on Evolut FX. But then we have a delivery system that is much more stable, and indeed it is stable when you're dealing, even you can feel that when you're dealing with more complex anatomies. And the fact that there are radiopaque markers at 3 millimeters, 3 golden radiopaque markers, they really help us understand whether or not there is commissural alignment, as well as help understand the depth of the valve, right? So, some of the features, as you can see, number one, look, if you pay attention to the nose cone of this device, I like to say that it's a more aerodynamic nose cone, so it makes it easier to go in the arteriotomy with that, in addition to the fact that it makes it much easier for you to cross the aortic arch. So it's less bulky than the prior generation, so it makes it easier for you to navigate more complex anatomies. Also, in the catheter, there is this optimized stability layer, which enables us to deploy the valve in a more coaxial fashion. So that's also a very important feature of the device. We note, and Gilbert presented earlier today our data in the US of the Evolut effects, that there's really not much of a discrepancy between the depth in the non-coronary cusp as well as in the left coronary cusp, so it's much better compared with the prior generation. As it was mentioned before, it's a single spine device. If you remember the Evolut Pro and Pro Plus and Evolut R, the dual spine device that you could bend in one direction and you could not bend in the other, with this device it's much more flexible. That patient that was shown before, the bicuspid patient, I'm sure that the navigation of this device would have been much easier with the Evolut effects. And finally, the enhanced visualization. So there are 3 radiopaque markers that they facilitate the understanding of whether or not we have commissural alignment, and obviously help us understand also the depth of the device. They're positioned at 3 millimeters in the inflow of the valve. Obviously, as I mentioned about the nose cone, so nose cone redesigned for access, much easier, not only for access, but also facilitates the crossing of those arches that are calcified, and sometimes you would remember, I remember some cases of Evolut Pro that you would get stuck on the calcium and you feel that scratch in the arch. This is much better, much easier to go. The single spine, as I mentioned, and the optimized stability makes it much easier for us to perform the procedures in more complex anatomies. And obviously, the understanding of commissural alignment is very, very important. And that is important because not only you can have the hat marker, which is what we use today, basically looking at the hat marker and the C-tab, but now when you have the commissure, the 3 golden markers positioned in a certain way, it's much easier to understand whether or not you have commissural alignment, as they're positioned right there where the commissures lie. In addition, this is data we just, I think it's important, the fact that it's at 3 millimeters, because 3 millimeters is really the name of the magic number, right? So this is data of more than 1,000 patients from our center. We just approved this data, and 3 millimeters is actually the number in the ROC curve that determines the higher risk for a pacemaker in every single eye, in patients with no prior conduction disturbance, patients with prior right bundle, or patients with left bundle branch block. So 3 millimeters is important, and that's where the markers are. So here, this is a case that's the same case that I presented. This is, of course, a fast-forward case, but I'm showing you some details that the crossing of the valve is very, very easy with this device, the crossing of the arch. In addition, you can see that I'm using a safari wire, right? A safari wire in a tortuous anatomy. With this device, we were using much more, with Evolut Pro and Evolut Pro Plus, we were using much more the Lunderquist wire. With this device, we're switching back to the Safari. A softer wire is very good to use with this device. So we've been using Safari more and more. I think it was mentioned before about the safety of the Safari wire, and this device works extremely well with the Safari. Then, once we cross the valve, we're going to see that the hat marker is going to be facing us in a cusp overlap view. I apologize that I cannot actually play with the video. I tried to trim it as much as I could, but in any event, so we're just confirming the position there of the pigtail. In addition, I want you to pay attention to this, right? Look at where I'm going to position the valve in the bottom of the pigtail. Remember that we have been using the valve like halfway through the pigtail because the Evolut Pro and Pro Plus, they dive more once you're deploying. This device, this does not happen. Of course, we tried multiple combinations. We tried different wires. We tried Safari. We tried Lunderquist. We tried to start the valve higher as we used to do with Evolut Pro and Pro Plus. And we noticed that we're doing much more recaptures with that, right? So we're starting basically in the bottom of the pigtail. That's what you see right there. And then obviously the other important aspects, remember the flush port at 3 o'clock, I don't know if you were here in the presentation that Gilbert did this morning, but by doing so, in the vast majority of the patients, you can obtain commissure alignment with this device. In our 168 initial patients that they presented. So, very stable deployment overall. We pace the patient at 140 to deploy as we do for every single case. And as you can see, there are 2 golden markers on the left-hand side and 1 on the right-hand side. And that's an indication that this patient has commissure alignment. So in this case, we were able to achieve commissure alignment. And obviously, the golden markers also facilitate the understanding of the depth, right? There are 3 millimeters, so we're happy with that depth. Then we're going to take this LAO picture to make sure we capture the left, which we did. We could see there, but that's routine, so we're going to go in LAO and take that same picture to understand that how deep we are on the left. And we were happy with the position there. So remember, when we have 2 golden markers on the left-hand side and using the wire as the division there, right? And one on the right-hand side, we have indeed achieved commissure alignment on that. And then finally, the final deployment of the valve, we do in the same fashion that we used to do for Evolut Pro and Evolut Pro Plus, in a very slow fashion deployment overall. Can you go to the next? Let me see if I can pass the next. Yeah. So, in addition, as was presented earlier today, with FX, the vast majority of the patients, we can see that they have commissure alignment by angiography. We are doing, however, we submitted these papers under review right now of post-TAVI CT, right? And the good news is when you have those golden markers on the left-hand side, 2 on the left, 1 on the right, or if they're evenly distributed, the vast majority of the patients that we did see that, they did have commissure alignment by post-TAVI CT. So that's also very good news because we are actually, this valve is actually delivering what's being promised, right? So I think that's basically what the case is. I'm happy to answer any further questions regarding the device or technique, anything else. Thank you.
Yeah, thank you so much. So we have time for maybe one quick question. So just tell us whether the improved flexibility of this catheter, does it help in attaining commissure alignment if you're not automatically there with a 3 o'clock position? So can you torque the catheter in a better fashion, in an easier fashion than the previous one?
Yes. Of this 130 something cases we've done, I had to consistently we went at 3 o'clock with the catheter. I just had to come back down to the descending aorta in 2 cases that we didn't have commissure alignment. So yes, we can achieve commissure alignment in the vast majority of the cases. I think that's a very positive, feature of the device, and the fact that there is the layer, the stability layer, and the single spine. Honestly, really improves the navigation these tortuous anatomies. When I saw the case that you presented, I immediately thought of FX because a case like that, I'm sure it was not easy to advance the Evolut Pro or Pro Plus. The FX would definitely make a difference in that situation. So
okay, great. So to summarize this very interesting session, very challenging cases, let's show the key learnings here. I think we've seen that valve-in-valve in small surgical prostheses may be challenging. It may require some advanced techniques for coronary protection and also importantly for adjustment of implantation height. We learned that there are some complex bicuspid phenotypes. They may result in frame under expansion and they require very careful attention to implantation strategy. And we've seen that the Evolut platform is evoluting So there is a continuous improvement that may further optimize acute and long-term device outcomes in challenging patient populations. By this, I would like to thank the whole panel here and the presenters, and thank Medtronic for hosting the session. And I think you are now free to go and enjoy your evening. Thank you very much.